Hi, everybody. Welcome to week 8. This is Kelly, your instructor, and we're getting ready for another riveting lecture. This is going to be on endocrine alterations, specifically diabetes type 1 and 2, and obesity. Let's begin. So, we're going to start with type 1. Basically, this is kind of like a juvenile onset diabetes. Autoimmune destruction of the pancreatic beta cells happens, causing little to very or to no insulin production, which causes hyperglycemia or high blood sugar. It's usually diagnosed in childhood or adolescence and requires lifelong insulin therapy. Nursing care would be regular insulin administration, um, monitor signs of hypoglycemia, low blood sugar. I think these are almost worse than hyperglycemia, shakiness, sweatiness, confusion. Um, and hyperglycemia would be polyuria, urinating a lot, polydipsia, extreme thirst, and fatigue. Educate patients on insulin administration and blood glucose monitoring. Those are important. Um, Insulin therapy, multiple daily injections or insulin pump. Glucose monitoring 4 to 6 times a day. Complications include DKA, diabetic ketoacidosis, hypoglycemia, cardiovascular disease, neuropathy, nephropathy, and retinopathy. So um, a little bit of nerve pain, kidney pain, possibly eye pain. Um, Clinical manifestations, rapid onset of symptoms, weight loss, polyuria, polydipsia, and palphagia. Diabetic teaching is big. You want to do that as early as possible. Teach to uh, count carbohydrates for meal planning. Hypoglycemic management includes keeping glucose tabs and glucagon, so you can pick up that glucose level really quickly. Sick day management, adjusting insulin during illness. Type 2, insulin resistance or relative insulin deficiency. This doesn't mean zero insulin production. There's some in the system, often associated with lifestyle factors and genetics. Usually diagnosed in adulthood, managed with lifestyle changes like diet, oral medications, and sometimes insulin. So there's insulin dependent diabetic, non-insulin dependent diabetic. Nursing care plan includes promote lifestyle modification, including diet, exercise, and weight loss. All three of these will help tremendously. Monitor A1C levels regularly. The A1C level measures sort of compliance or blood sugar levels over time. Educate patients about the importance of diet and exercise in managing diabetes. And that's kind of an overall theme in this slide, or this slideshow. Pharmacological treatments include oral anti-diabetic medications like metformin or glipizide, insulin therapy if needed, and there are a lot of new medications out there as well. Glucose monitoring, regular blood glucose testing is directed. Some complications similar to type 1, but often develop a lot more slowly. Clinical manifestations, a gradual onset of symptoms, fatigue, recurrent infections, blurred vision, and slow wound healing. Most adults that develop type 2 diabetes really don't know it until they get checked out. So type 2 diabetic teaching, pretty close to type 1 weight management strategies, and maybe not so much for type 1. importance of adherence to medications, and self-monitoring of glucose. Shared considerations for both, um, as mentioned before, promoting regular physical activity, encouraging a balanced diet with focus on low glycemic index foods, and that can be found on the internet pretty easily. Monitor for signs of hyperglycemia, encourage regular follow-ups with healthcare providers, and emphasize the importance of diabetes self-management education programs. Some nursing diagnoses for these two include knowledge deficit, risk for unstable blood glucose levels, impaired skin integrity. Diabetics tend to not heal as fast if they have a wound. Risk for infection, risk for injury, risk for deficient fluid volume, risk for coping ineffective for individuals and families. 3 levels of patient teaching include survival skills, basic knowledge and skills in diabetic management, home management, and improving lifestyle. The assessment includes observation. Is there pain during ambulation? Do they have sores on their feet? Um, Interview, family history of diabetes, history of cardiac problems or any of these other issues. Changes in vision, do they smoke? Frequent voiding, which could be a sign of diabetes. GI function problems, and I'll let you look at the other two. Physical exam and diagnostic exam, touch, the skin hot or cold. Vital signs, vision, skin for lesions, especially feet. And sometimes they won't know if they have a sore on their foot because they won't be able to feel it as much. Some diagnostic exams, you should probably know these. Fasting blood glucose is normal is 70 to 110. The normal hemoglobin A1C is under 6.5%, and cholesterol under 100 milligrams per deciliter, and triglycerides under 150 milligrams per deciliter. So basically, you want the patients to really understand these levels. Nutrition management via the ADA guidelines, excuse me, and try to maintain near normal blood glucose levels if possible, and it is possible. Achieve optimal serum lipid levels, provide adequate calories, not too much, not too little, treat complications of insulin-treated diabetes, short-term illness, exercise-related problems, overall health through optimal nutrition, meal planning. Balanced diet includes 30% fats, 30% protein, and 40% carbs. So there's good carbs and bad carbs. Look that up. Consistent carbs, diabetes meal plan, exchange lists, etc. You can look at that. And the important thing is diets should be tailored to the individual. All right, more nutrition management. Carbs should come mostly from grains, fruits, vegetables, milk, and some dairy products. Sucrose substituted for other carbohydrates does not impair blood glucose control. Dietary fructose, small rise in glucose than sucrose, most starches. That, moving on. Alcohol consumption, we want to try to encourage that. Some alcohol is prohibited or is not prohibited, so they can drink a little bit. may potentiate hypoglycemic effects of insulin and oral agents. Signs of intoxication and hypoglycemia are pretty similar. Increased risk for insulin reaction. And alcohol should be consumed with meals if they're going to have it, including daily food intake, or included in daily food intake. Exercise. A few teaching points would be to um, improve glucose use by muscle cells, reducing need for insulin, decreases cholesterol and triglycerides. Type 1 diabetic considerations. Exercise induces, or exercise-induced hypoglycemia lowest before breakfast. Moderate and regular exercise. Intense exercise can cause hyperglycemia. Prolonged exercise causes hypoglycemia. So for type 1 diabetics, you have to find a good balance. Avoid exercising at peak insulin action. Glucose monitor before and after exercise. Food intake may need to be increased. So blood glucose level under 100. Treat with carbs prior to exercising, because that could drop it pretty good. Type 2 but diabetic exercise is more focused on weight loss in overweight individuals. Improves glycemic control, increases well-being, decreases cardiovascular risks, and often decreases the need for oral hypoglycemic agents. I'll let you look at the bottom one. Foot care is important. Teach the patient to check their feet daily for sores and cracks in the skin. They may need to use a mirror. Wear appropriate fitting shoes, not open-toed shoes. Careful careful toenail care is essential. Dang. Trim after washing, cut straight across. Childhood and adolescence in type 1 diabetes. More frequent glucose monitoring for children. Different targets because of erratic oral intake. By age 6 to 8, most children can take some responsibility, so teach them young. Insulin daily doses depends on the child's age, weight, and stage of puberty. Nutrition intake, exercise patterns, what's the daily routine, results of glucose monitoring. Excuse me. Correct dose achieved best control without causing hypoglycemia. So that's going to take a little bit of messing with to get it right. Adjust insulin to cover carbohydrate intake during meals. Children with type 2 diabetes is relatively uncommon, may be less acute than those of type 1. Remember, they still produce some insulin. Symptoms related to hyperglycemia. Nutrition and exercise are keystones for this, for kids. And for children with type 2 diabetes, metformin is the only oral hypoglycemic medication approved. Evaluation. Expected outcomes. The patient demonstrates age-appropriate understanding of diabetes self-care management. Skin integrity remains intact. It remains free of infection and injury. If the outcomes are not met, assess the diet and medication adherence and teach on that and try to develop or redevelop or modify the plan. Obesity. Exemplar 14A. Let's begin. So, prevention, and for parents, apparently it starts before birth. The parent's role is to promote good nutrition in the home, And if the parents don't know it, that's not going to happen. Encourage in-family style dining, limit TV, others sedentary behaviors, patient education in all settings, and partnership with public health organizations. Clinical manifestations, upper body versus lower body obesity. Upper is more intra-abdominal fat, higher levels of circulating fatty acids. Lower body obesity, more common in women and harder to treat. Um, the BMIs you'll want to know: overweight, 25 to 26.9, obese, 30 to 39.9, and extreme obesity, over 40 BMI. Assessment, again, observation and patient interview. A general appearance, posture, and gait. What's their current and usual weight? Recent weight gains or losses. What's their diet or food intake? That's important to know. Exercise patterns, activity patterns, comorbidities, medications, patient's body image and perception of weight. A few diagnostic tests here. I'll let you read that. A few nursing diagnoses: overweight, risk for, obesity, low self-esteem, knowledge deficit, activity intolerance, health maintenance ineffective. Implementations focus on diet, exercise, and behavior modification. The behavior modification can take a bit of time to accomplish, but it's possible. Encourage the patient to identify factors contributing to excess food intake. Establish realistic weight loss goals. Assess patient's knowledge. Discuss a well-balanced diet plan. And discuss behavior modification strategies. Monitor weight loss, blood pressure, labs or lab data. And you can look at these two for the two different BMIs. Exercise is a critical part of losing weight and keeping it off. Increased body or energy consumption promotes weight loss, prevents or preserves lean body mass. And I'll let you read the other two. I think diet and decreasing calorie intake is going to be the biggest thing here. Nutrition management, very low calorie diets. There are a lot of different diets out there. Close to medical supervision, associated exercise, nutrition, and behavior modification counseling. And let's see, hunger suppresses ketone production and not applicable for individuals age 50 and over for very low diets. And then the extreme is surgery, limited to certain patients, morbidly obese and unable to lose weight through diet or exercise, has serious obese related problems, including metabolic syndrome, hypertension, heart disease. They need to be free of addictions, must be able to tolerate surgery and undergo psychological evaluation. And they have that prior to a surgery being approved. So those are kind of important before getting this type of surgery. A lot of complications. The anastomosis may leak in the causing peritonitis. I can't even talk today. Gallstones, wound infection, DVTs, nutritional deficiencies, GI symptoms, and dumping syndrome. And the last slide for week 8, this is kind of a short lecture. Expected outcomes include patient identifies, understands factors that contribute to weight gain, Patient understands and applies behavior modification techniques for reduced weight, accomplishes desired weight loss at a rate of 1 to 2 pounds a week, and there are apps on phones for that to keep a little bit more track. And patient incorporates physical activity into their daily routine. Well, that is it, everybody. Thank you for watching, and I'll see you soon.